I have the basically task to give you a short overview on imaging in spondyloarthritis and PsA, especially first starting with bread and butter concepts and then having some new imaging techniques presented here. These are my disclosures, and it starts actually that PsA and axial spondyloarthritis are very different from rheumatoid arthritis. It's often not possible to see swelling because enthesial structures are involved, and therefore actually diagnosis is often cumbersome because it's only related to pain, and therefore imaging is very much needed. And here you can see basically that enthesitis is actually an inflammation of the outside the bone at the insertion side of the tendon, and osteitis. Osteitis is actually a domain of MRI, and the outside of the bone, of course, you can see with MRI and with ultrasound. And these are the key two imaging technologies, and we hear from that later by Dennis and by Rai and by Maria Antonietta how they are used. The other important part in the disease is that the enthesitis leads to substantial tissue responses which impair the quality of life of patients. That happens in the axial skeleton, like in axial spondyloarthritis with syndesmophyte formation, and Dennis will speak about that later, but also in the peripheral skeleton, like, for instance, calcaneal spurs and Achilles tendon spurs. This image actually on the right side was provided by Peter Herz, a dear friend in Munich, and you can basically see very nicely that even in the conventional X-ray you can distinguish PsA very nicely from rheumatoid. There is this fluffy appearance of the periosteum here and here and here and here, which is a typical feature of enthesitis at the classical joint. It's not an intra-articular process, an extra-articular process with inflammation of the periosteum and later bone responses. Now, this is very important because over time, tissue responses progress and lead to impairment of function, which is both involving the axial skeleton with this classical imaging of axial spondyloarthritis, or AS in this case, in the left, but also in PsA, where you basically see at the right-hand side that there is a massive osteoproliferation happening in the joints, and this gives the typical feature when we palpate joints of PsA patients with a bony swelling, sometimes resembling features of osteoarthritis. Now, why is this important? Why imaging is important? Well, we have a lot of cool treatments now to abrogate inflammation, and we have learned a lot how actually which cytokine inhibitions are working in PsA and axial spondyloarthritis, and you can see psoriasis, psoriatic arthritis are in this branch with IL-17, IL-23, and TNF, which is a common root of these diseases. And axial spondyloarthritis is a very 17 TNF-driven disease, as you know. Now, why is imaging important? There are 3 points. As mentioned, often there is no swelling because it's enthesitis, so one has to rely only on pain, and obviously pain is very heterogeneous and it can be inflammatory, non-inflammatory, and therefore imaging to basically check for inflammation is important. The second part is that we cannot always rely on C-reactive protein, which is often absent in psoriatic arthritis and spondyloarthritis, because there is not a key role of interleukin-6 in the disease. And finally, there are sad tissue changes in PsA and axial spondyloarthritis, which can be picked up with imaging, and we will hear from that later. So the 2 key technologies are ultrasound, and Maria Antonietta D'Agostino will speak about ultrasound. It's the detection of a power Doppler signal, for instance, here in the Achilles tendon, showing actually inflammation. And obviously, ultrasound is also able to detect tissue responses. Ultrasound is not very good in the spine. It's not very good for osteitis, should stand there, but it's also not good for the spine. And you may prove me false, Maria Antonietta, but ultrasound is not always the perfect thing. MRI is working in peripheral and axial disease, but there are actually downsides and upsides of both technologies. MRI is pretty cool because you can detect osteitis. This is just one image of Achilles tendon enthesitis, where you see basically the outside inflammation, water enrichment, and also the inside inflammation, which is osteitis, and in between the bone lamella. So it allows to basically give a comprehensive picture of the disease process, and we use that sometimes to basically detect inflammation. MRI this is from the Berlin group, is also sometimes very helpful to look at the global picture of inflammation and show that there's a composite of axial and peripheral disease. As you see here, there is inflammation in the spine. At the same time, there is enthesitis at the shoulder, the trochanter, and the knee. So it gives whole body MRI a comprehensive picture of inflammation, but that's actually reserved to specific centers. MRI and ultrasound allows to define a group of psoriasis patients with high risk to develop PsA, as you see here. When there is inflammation present, as you see here, and pain present, the progression to psoriatic arthritis is very high, and that allows in the future early intervention. And this is one example for early intervention in psoriasis patients with secukinumab, where you can see that the drug can actually wipe out these enthesial lesions here in the wrist joint and in the MCP joint, and also improve pain, the global VAS, and the PsA, which is a quality of life instrument in psoriatic arthritis. So early detection of inflammation in psoriasis is possible, is feasible, and early intervention is also feasible. Now, these technologies are usually picking up inflammation, but the quality of the process is not very well picked up. There are other technologies that's near-infrared imaging, where you basically inject a dye, which is indocyanine, and then you basically look at the emission of light after stimulation. And basically here is the red parts are actually highly vascularized lesions in the joints, but also in the skin in a patient with psoriatic arthritis. So that's a rather feasible technology, which is, I think, growing in the future. And then there are more sophisticated tools to actually not to use a biopsy of the joints, but actually to look at the molecular profile in the joint by non-invasive method. That's the so-called MSOT technology, which is called multispectral optoacoustic tomography, where you are able actually to look at oxygen saturation, hemoglobin levels and collagen levels and lipid levels in joints. And in the left, you can see synovitis. In the right, you can see enthesitis, and there are remarkable difference. For instance, oxygen consumption in synovitis is much higher than in enthesitis, but vice versa, collagen content is increased in enthesitis, reflecting actually this tissue proliferative responses in the disease. So we are actually on the way to understand the molecular process and the difference in molecular processes, synovitis and enthesitis, by non-invasive imaging technology. The second part of the disease, and we will hear from that later, is actually tissue responses. As you see here, I mentioned that these are the enthesiophytes which form in a patient with psoriatic arthritis, and that's a very dynamic process that can happen within a few weeks. Obviously, what we want is to understand that better. And there is a technology which is borrowed from from oncology to actually assess tumor stroma activation. And basically, what you can do, you could use a tracer against fibroblast-activated protein, which is actually labeling activated fibroblasts. And this is extremely effective in spondyloarthritis and in psoriatic arthritis. There's a nice poster at this EULAR. You can see basically tissue responses in the knee joint, in the supraspinatus tendon. This is dactylitis, as you can easily recognize, and this is Achilles tendon enthesitis. So it allows you to separate inflammation from tissue responses. You can see, for instance, that's very effective in psoriatic arthritis in the peripheral joints. Here is actually the VAS pain scores in patients with psoriatic arthritis, and you can see basically the higher the activity of the disease, the more there is tissue responses detectable. You can also use that in the sacroiliac joint. As you see here, you walk through the sacroiliac joint and you can see this fibroblast activation spot in the sacroiliac joint, which is actually the preceding ankylosis of the sacroiliac joint. That's not inflammation, that's purely tissue response, which is pretty interesting. And also we see that there is a very strong association between disease activity as measured by ASTAS and this fibroblast activation in the joint. So it allows you actually to have new possibilities to detect tissue responses on a much more dynamic way. This FAP pad is also responsive to change. As you see here, that's baseline and after IL-17 blockade, and baseline and after TNF blockade in axial spondyloarthritis patients. And you can basically see that that cytokine inhibition also abrogates these tissue responses, which is probably very important because it has structural effects and prevents the progression of syndesmophyte formation, but also enthesiophyte formation in the periphery. Now, to sum up, what I wanted to share with you is that ultrasound and MRI are mainstay imaging technologies for detecting inflammation and treatment responses in PsA and axial spondyloarthritis. There are new technologies underway which are able to measure vascularization and the metabolic profile in the joints and in the entheses. Then there is high-resolution CT, which allows the visualization of anabolic bone responses in PsA and axial spondyloarthritis. And finally, there are new PET technologies which allow basically to segregate inflammation from tissue responses in the disease, and actually probably allow to do much shorter trials and much smaller trials to look at the effect of certain drugs on the tissue response. At the end, I want to thank the collaborators, Andreas Ramming and Christina Bergmann, who's doing FAP-PET, and also Jörg Distler, and the people who from the nuclear medicine who were involved, especially Christian Schmidt-Konz and Thorsten Kuber. Thank you for your attention.